Good evening, everyone, and welcome to the British and Irish Hypertension Society first of hopefully many more webinar series. It's the BIHS's efforts to try and educate and train colleagues in practice, and the emphasis is that we have this multidisciplinary approach, and the emphasis is on trying to equip you with skills that you can utilize in clinical practice. So we have three excellent presentations, and what I would encourage you to do is to use the live Q&A facility and ask all your questions. We'll wait for the presentations to go through, and then we'll start a live Q&A session with members of the panel, which you have details of. So I think we'll start, but please do use the live Q&A facility to ask your questions. Thank you.
My name is Philip Lewis. I'm grateful for the opportunity of talking about practical blood pressure measurement and monitoring. Here are my disclosures. And I'm going to start by talking about measurement itself. The Chinese recognized diseases associated with the heart pulse as early as 2,500 years BC, and the Egyptians recognized that these could affect both the heart and brain 1550 years BC. But it wasn't until the Reverend Stephen Hales, working in a laboratory in Cambridge previously vacated by Sir Isaac Newton, that we were able to know what pressures might be achieved. Initially, he experimented on dogs, and later on horses, and found in one old mare that the pressure rose 9 feet above the heart and rose and fell with each pulse. 19th century researchers developed techniques which were predecessors to the current ways in which we measure blood pressure, starting with Poiseuille, who used a mercury column in his medical student thesis, to Ludwig, who tried to record it, Van Ferrot to measure it with weights, Meyrie to use a wrist recorder externally, and von Basch, who used a water-filled bag pressed against the artery, and then Dudgeon, who tried to use a compression technique attached to a kymograph and quite successfully developed a way of recording blood pressure. Scipione Rivarocci developed an air-filled bag attached to a mercury manometer. He put the bag around the arm and found out how much it would have to be inflated before the pulse measured at the wrist disappeared. This is the predecessor to the mercury sphygmomanometer, which we now recognize. Nikolai Korotkov, a Russian military surgeon working in the Russian-Japanese War of 1904-5, tried to find ways to predict if limb blood flow would be viable after surgery on traumatic arterial aneurysms. He noted that with complete compression using a Rivarocci cuff, the arm aneurysm disappeared, and when cuff pressure was gradually decreased, a series of sounds could be heard by a stethoscope over the artery distal to compression. He reported this in November 1905, and this was the first easy and accurate method to determine both systolic and diastolic pressures, and has remained the gold standard of non-invasive blood pressure measurement more or less to this day. The word sphygmomanometer comes from Greek words meaning measurement of a small pulse. It depends on the assumption of complete occlusion of the limb artery by an external cuff, with disappearance of arterial flow, and thus of pulsation and the associated Korotkov sounds, followed by restoration of pulsation and sounds until the diastolic pressure is reached, when the artery is no longer compressed. The sounds which are detected approximate to intra-arterial systolic and diastolic pressure. The measured systolic is the first of the series of regular, easily heard tapping sounds, and the diastolic is the last of these regular sounds. Good auscultation requires training. The BIHS provides a widely used training resource on our website with a commentary on a series of duplicated readings, such as this one, in which irregular readings are heard till 140, then regular readings between 140 over 88. Other irregular non-repeated readings can be ignored. Besides ensuring that observers are trained to listen to the blood pressure sounds, their auditory acuity should also be assessed if necessary. Ambient noise should be minimized, and a reasonable quality stethoscope should be used. The cuff shouldn't be deflated too quickly. Some people find it difficult to coordinate what they see and what they hear quickly. If pulse rate is slow or irregular, it may make it also more difficult, and repeated readings may be necessary. The stethoscope should be placed over an artery which has been palpated initially and then obliterated by cuff inflation to 30 millimeters above the point at which the pulse has disappeared. When listening to the sounds, the preference to look at zeros and fives should be avoided, and blood pressure is recorded to the nearest 2 millimeters. If someone's standing over a patient, the patient might find that quite intimidating, so they should both be seated and both silent. It's been noted that short stethoscope tubes make it easier to hear systolics, that the diaphragm is not as good as the bell in picking up most diastolic sounds, and if the diaphragm or bell is put under the bladder, the diastolics seem to be higher than if it's not under the bladder, and this may be a better way of recording it, since diastolics by auscultation may be slightly lower than intra-arterial recordings. I now want to deal with the pressure gauge used to measure the pressure itself. Mercury, which has long been the gold standard, is now unavailable because of environmental and safety reasons. Aneroid machines and solid-state transducers have replaced mercury, and especially solid-state transducers, as they are accurate and now not very expensive. Here's a cutaway of an aneroid, and you'll see that there's a bellows inside which pushes a lever which moves the pointer. The problem is the bellows can be deformed either by overinflation or even with different temperatures, and the needle can be displaced. So for this reason, aneroid machines should be calibrated every 6 months at least. This is rarely the case. The aneroid machine shown in the previous slide has not been validated, but these in this slide have. But nevertheless, they still need to be calibrated every 6 months if possible. One should always only use validated equipment. Solid-state pressure gauges may be extremely accurate and reliable and require infrequent calibration. Some, such as the green monitor on the right, automatically recalibrate to 0 when switched on. All require a power source, which is either a battery, which may last up to 170 or more hours of use, or mains. The accuracy of the manometer does not, however, avoid the need for skilled auscultation. Be careful. Not all cuffs are equivalent. We placed a 16 by 6 piezoelectric pressure sensor array under a series of cuffs placed around an artificial arm. On the left, you can see 3 cuffs put around this arm. The top cuff, which is a disposable cuff, has caused very small pillows around the arm. The lower cuff has produced much bigger pillows with large gaps as well, and the blue cuff in the middle is having an effect halfway between the top and bottom cuffs. The 2 tartan-like displays labelled A and B represent pressures measured by the 96 sensors under 2 individual cuffs. On the right-hand side of each of the displays are the pressure calibrations. You'll see in A that there are a lot of pressures measured around 50 millimeters mercury, but there are others between 250 and 400, although the intra-cuff pressure was 120 millimeters at this time. In B, which was also inflated to 120 millimeters, the average sensor pressure is much more close, with levels between 70 and 120 millimeters. We then did some computational modelling of the theoretical pressures sensed around the brachial artery in 8 different cuffs, loaded with sinusoidal pressures of 125/85, and estimated what pressures would be applied to the arterial wall. You can see that in cuff 4, the pressure estimated at the arterial wall was within 95% of the applied pressure, which was 125/85. But in other cuffs, only 76 to 88% of the pressure within the cuff was theoretically transmitted to the arterial wall. Thus, not all cuffs are by any means the same. Not only does material construction of cuffs differ, but also their size and shape relative to the arm. Too small a bladder needs inflating to a higher pressure to compress the artery and will overestimate blood pressure. An over large cuff will underestimate blood pressure. You can see the magnitude of differences in systolic and diastolic pressures measured with small and correct size cuffs in this study. And this sort of error applies both to automatic and manually recorded blood pressures. How do you occlude the artery in an arm with a bingo wing? You can try and use a large enough cuff if you have one, but that's not always possible. Another way is to put the cuff on the forearm and either attempt to auscultate or use Doppler over the wrist, or otherwise use an automated machine. It may not be as accurate as ideal, but it might be better than nothing. If one uses a rectangular shaped cuff on a conical or troncoconical arm, the upper part of the cuff will compress the arm well, but the lower part won't. And indeed, a cylindrical cuff will overestimate blood pressure, but not a conical cuff. So a conical cuff would be much better in this situation. If arm artery flow is abnormal because of a shunt, vascular disease due to occlusion, giant cell arteritis, or congenital abnormalities such as thalidomide-induced phocomelia, blood pressure could be measured using an ankle cuff, providing there is no lower limb vascular disease, but systolic pressures are about 15 millimeters higher than the upper limb, so a threshold of 155/90 should be used to define hypertension in this situation. I now want to talk about automatic blood pressure recording, which almost always uses the principal oscillometric measurement. In this, the pump inflates the cuff to a point above arterial pulsation into the arm, and then as it deflates, pulsation resumes, as can be shown first of all in the pressure trace, and then the Doppler indicates return of blood flow. However, this is not the same as auscultation. The transducer attached to the cuff works out the point of maximal pulsation and then upslopes and downslopes, and estimates using a variety of algorithms what the systolic and diastolic pressures would have been. These are rather black box effects. Just because machines measure blood pressure, they don't all measure it accurately and aren't all validated for every purpose. In this study, we looked at a very good home blood pressure monitor and measured pressures simultaneously by auscultation and using the monitor. An example of how much this can be out is shown in the patient ringed in blue, where the diastolic average of the two pressures was 85, But given the 15mm difference between the two, that meant that the automated blood pressure was 78.5, but the manual reading, which in pregnancy we would have trusted, was 91.5. So whilst this patient was technically hypertensive for pregnancy, we would have been given false reassurance that their blood pressure was normal had we used a blood pressure monitor not validated for use in pregnancy. There are a large number of oscillometric monitors available for a variety of indications. The BIHS continues to maintain an independent, non-commercial list of validated monitors which you can refer to. Please consult our website to find out which monitors we recommend and which haven't been validated. The next speaker, Professor Richard McManus, has reported that home monitors which are more than 4 years old and those that cost under £10 are more likely to give unreliable readings. So how should blood pressure be measured? Please ensure that all blood pressure readings are made using these standards in a relaxed patient, not needing to go to the loo, seated with their back against a rest, both feet on the floor, legs uncrossed, with neither the observer nor the patient talking, a correct size cuff properly applied on a bare arm supported at heart level, and preferably with no exercise, smoking or caffeine in the previous half hour. Repeating blood pressure measurements tends to reduce blood pressure, probably not just because of acclimatization, but also because of physiological changes. And some people will record lower blood pressure measurements than others, not just because they're necessarily deaf, but because the patients feel more relaxed with them. Because of possible asymmetry of readings of blood pressure in both arms, it's worth at least once measuring blood pressure in both arms, and if one is consistently higher than the other, the blood pressure measured on the higher side should be used thereafter. I always measure manual blood pressure 3 times in both arms in all my patients for the first time, and use the average of the final 2 readings in the highest arm once the blood pressure is stabilized. Some women believe that measuring blood pressure in an arm on the side of a breast cancer surgery or with lymphedema could be dangerous. This is not true, but argument may achieve little in trying to persuade the patient that it's safe. Standing blood pressure is always worth considering, especially in those who report lightheadedness. This may be more likely with diuretics, alpha blocking and age, and I recommend the blood pressure is first of all measured twice seated and then immediately after standing and 1 minute later, and in young people at 3 and 5 minutes. Please ensure that the arm is supported at heart height, in other words with the elbow about the level of the lower ribs. A standing blood pressure drop of 20/10 from supine is equivalent to 1/15/7 from the sitting position. Automated monitors may not work particularly well if there's an irregular or slow pulse or where the pulse volume is low, such as in young females with slim arms and in frail elderly people. Because blood pressure measures from day to night, moment to moment, season to season and so on, and also because the risk of blood pressure is more related to nighttime than daytime and daytime to clinic readings, the use of ambulatory and home readings is more important than clinic readings in determining what is hypertension and when it should be treated and to what degree it should be treated. Home blood pressure recordings require the right size cuff on the upper arm, the lower edge of the cuff 2 finger breadths above the elbow bend, the centre of the bladder over the brachial artery on the chest side of the biceps, tight enough for only 1 finger at most to get under the top and bottom of the cuff. The patient be sitting quietly without talking for 3 to 5 minutes. The blood pressure should be taken, read and recorded, a minute waited and then a second reading taken and recorded, and possibly a third if the patient is in atrial fibrillation. This should be repeated morning and evening before taking medication for 4 to 7 days sequentially, and then again 10 to 14 days after any change of medication to determine the effects of that medication change. The average of readings is always required for decisions about diagnosis and treatment, and these can be communicated via a variety of methods such as an app, a Florey, or a spreadsheet. For home standing blood pressures, the arm must be supported at heart height with the reading done immediately on standing and again at 1 and possibly 3 and 5 minutes as previously discussed. Adequate standards of blood pressure measurement by ambulatory readings are just as much required as for home or office readings. At least 20 daytime readings are required or 7 nighttime readings for a proper evaluation of night and day blood pressure, and the patient should be adequately prepared for the use of the machinery. In summary, it's important to use the correct equipment, technique, training, maintenance and education for good blood pressure measurement.
Hello, my name is Richard McManus. I'm a GP and Professor of Primary Care Research at the University of Oxford. Today I'm going to talk to you about face-to-face versus remote management of hypertension. These are my disclosures. So in this session I'm going to give an overview of what I see as the problem in hypertension management, discuss what we know about home monitoring, consider the use of self-monitoring with digital interventions and also self-management, and then move on to thinking about implementation and coming to a conclusion. So what's the problem? Well, around half of people whose blood pressure is above 140/90 are unaware of this fact, and a third of those who are aware and are currently being treated are uncontrolled. This poor control is due to a range of reasons, both to do with the patients themselves in terms of adherence, side effects from medication, mismatch of their idea of risk compared with the clinician's idea of risk, and lifestyle factors. In terms of professional factors, workload, which I'll come to shortly, is a big issue, as is lack of professional action and guidance, which in the past at least has sometimes been confusing. Workload, well, any of you who are GPs will know how this feels in terms of the Daily Mail, but also workload in hospital is obviously also been significantly impacted by COVID, despite the fact that the current wave is not as bad as was previously thought. This comes on the context of clinical inertia, where we know that even when we're able to see patients in more normal circumstances, both hospital and primary care clinicians tend not to necessarily intensify medication when it might otherwise be appropriate. Now, the current context in terms of primary care, where the large majority of hypertension care takes place, has massively changed, and most practices are now using remote consulting and indeed remote blood pressure management for the vast majority of their hypertension care. And this is the case in addition in many hospital clinics. This is some unpublished data from a preprint from a study led by my colleague Claire Bankhead, and this shows you the on the left the number of blood pressure measurements that were happening before the pandemic, and you can see where the vertical line is represents the end of March 2020, where those measurements basically fell off a cliff, and you can see that after that the level gradually rises, but only up to where I've drawn the red horizontal line, which, as you can see, is less than half of the blood pressure measurements are being recorded in our clinical systems than were prior to the pandemic. And you can see the effect of that on the right, with a small increase in the number of blood pressure measurements happening following the pandemic, but really nowhere near recovering to normal levels. This is important because delaying care can have a real impact. This paper from Zhu et al. Shows that delays more than about 6 weeks of medication intensification can lead to increased cardiovascular events, and this is worse for those with higher blood pressures, particularly above 150 systolic. So what do we know about remote monitoring? Well, around 40% of people in the UK with hypertension are currently self-monitoring. That's more than 3 million. And similar proportions in the US and China. We know that the monitors that people have are generally accurate, particularly if they are 4 years or less old and if they are previously validated. Those that did fail in this study that we did were in general older monitors and were more likely to fail if they had a large cuff. We know that self-monitoring is now very widespread. This graph on the bottom left shows you the impact of the NICE hypertension guidelines on the recording of home monitoring in the primary care clinical record. And we know from surveys that we did before and after the 2011 guidance that there were big changes in the proportion, particularly using self-monitoring for the diagnosis of hypertension, but ongoing high proportions of GPs using self-monitoring for the ongoing management. How many days of measurements should be required? Well, most of the guidance suggests that you should do a week of readings, 2 in the morning, 2 in the evening, and at least 3 or 4 days, depending on whether or not you are dropping the first day. When we looked into this in some detail, it suggested that that perhaps dropping the first day was less important. Certainly if you're doing 7 days of readings, perhaps if you've got fewer days of readings, it becomes more important because people tend to relax a bit after the first day. So the blood pressures on the day 1 tend to be different from subsequently. We also know that self-monitoring allows goal setting in advance, and this is where as clinicians we make a decision as to what changes we might make should a patient's blood pressure remain above target, and these include the potential for reviewing the record before an episode of self-monitoring, making a plan which some clinicians are happy to let their patients follow. More on that later on in the talk, and then the potential to reassure patients that their self-monitoring blood pressure is likely to be lower than that in the clinic, and that the targets are in widespread use. So if one is going to use self-monitoring remotely, one really needs an integrated digital system to do this in. And I'm going to talk to you about the home BP trial, which we published last year, which compared a digital intervention combined with self-monitoring of blood pressure with usual care, which was largely clinic-based monitoring. Patients were able to feed back their blood pressure results using a specially designed website, and the intervention also allowed them to get lifestyle advice. Digital interventions are helpful because they allow medication planning, which I've just talked about. They allow prompts for both patients to monitor their blood pressure and healthcare professionals to do something about it if it's high. They allow improved communication, largely because the communication can be asynchronous, so patients can send messages to their clinicians and vice versa without needing to be in the same room at the same time. But nevertheless, they do allow real-time feedback, both through automated messages back to patients and also for professionals, particularly if the blood pressure is very high or very low. You can incorporate training, and indeed all the training in the Home BP trial was done online, and you can increase intervention intensity without increasing workload. In Home BP, the primary outcome was systolic blood pressure, and indeed we showed significant improvements in the intervention group compared with usual care. We found no difference in side effects and high medication adherence throughout. About 50% of the control group did ad hoc self-monitoring themselves, which may have had a bearing on the fact that the headline reduction in blood pressure of 3.5 millimeters of mercury was a little less than we'd seen in other trials. The intervention seems to work by both engaging patients in the long term. Over 70% were still monitoring 9 months into this trial, and the main mechanism of action seems to be appropriate use of medication with both dose increases and new medications to reduce blood pressure. Costs in this trial were modest, with £11 per millimetre mercury blood pressure reduction, and indeed modelling that we've done in other trials suggests that such interventions are cost effective. We also have looked previously at whether patients can do self-titration over and above self-monitoring. So what do we mean by self-management? Well, in the context of these studies, it was self-monitoring with self-titration of antihypertensives following a pre-specified schedule. Some of the trials include telemonitoring, others not. GPs and patients meet at the beginning of the studies to decide 2 or 3 medication changes the patient can make without needing to reconsult, and further medications can be added or increased as necessary. The systems all allow additional monitoring where necessary, for example for ACE inhibitors. We use a traffic light system with red for very high, blue for very low, amber for raised blood pressure and green for normal blood pressure. And all the targets are adjusted for lower home blood pressure, with lower targets in higher risk groups. In both these self-management trials, we saw significant reductions in systolic blood pressure at a year, 5.5 in the essential hypertension trial, 9 millimeters systolic in the high risk group. And as with Home BP, good adherence to medication, good adherence to the intervention with 80% self-managing for the full 12 months, and increases in medication, both due to additional antihypertensives and additional doses. Side effects very similar between those self-titrating and those not. The only thing we've ever found was a slight increase in ankle swelling in those people in the essential hypertension trial, probably driven by increased calcium channel blocker use. And as I mentioned, where we've done economic modelling, this shows self-management interventions to be highly cost effective. So how can one fit self-monitoring and telemonitoring interventions together? Well, we've done a systematic review using individual patient data to allow us to directly compare a whole range of studies, 25 trials from the world literature. And what we've shown is that if you just hand someone a blood pressure monitor in the context of very little co-intervention, that very little effect happens with that. You don't get any worse effect than usual care, you just get similar effect to usual care. But as you add things like telemonitoring or more intensive interventions such as self-titration, or even pharmacists doing intensive communication with patients on a monthly basis, you get gradually increasing amounts of blood pressure reduction. to give you an example, on this, low intensity is the ones where you just give a monitor. High intensity is a pharmacist ringing every month. Telemonitoring and self-titration falls somewhere in between. So what about real life? So one good thing about the pandemic has been that the resources for patients have been significantly improved, notably by the third sector. This is the page from the British Heart Foundation self-monitoring of blood pressure website, and they've got some really nice resources with instructions on what to do, advice on what monitors to use, and so on. This has been matched by increased investment by the NHS, and more than 200,000 monitors have been purchased by NHSX and distributed around the country. Initially, these were taken up by Trailblazer sites, as you can see on this slide, but these are coming down into daily practice, and many practices are receiving consignments as the weeks go on. Just as I say, having monitors is not the only thing, and these monitors, 200,000 in the context of perhaps 8 million people on hypertension registers, could be considered to be a bit of a drop in the ocean. However, I think that they're extremely useful in the context of patients who maybe cannot afford to buy their own monitor, and can be added to the 40% of people who already have their monitor, allowing really quite significant potential for the use of remote monitoring. So in conclusion, many patients have suboptimal blood pressure control, and this is likely worse from the pandemic, with many fewer blood pressures being recorded in the clinical record. At least 2 in 5 have their own monitor, and most of these are accurate, particularly those 4 years old or younger. Digital solutions allow increased intensity of intervention without increasing workload, and some of these are becoming available in daily practice, and you may well have those integrated in your clinical system. Patients can do this too, giving people simple advice as to what to do if their blood pressure remains high can work, and is certainly something that I use. Implementation is now key, but isn't straightforward. We are getting more monitors provided, but you can't still prescribe a blood pressure monitor, despite the fact it's only perhaps £15 or £20, particularly if bought in bulk. So be interested to hear what you are all doing. That comes to the conclusion of what I was going to say. Just like to acknowledge that the research that I have presented that involves my group was certainly not just done by myself, and was done by a very large group of people. Much of my work is funded by NIHR, and obviously none of that research could have been done without both patients and their practices. That was all I was going to say today. Thank you very much. Thank you very much.
Good evening, everyone. My name is Sam Alden. I'm the Head of Exercise and Science and Lead Physiotherapist at CPNR. I'm also the Chair of the Nurses and AHP's Working Party at the BIHS. Today, I'm going to talk to you a little bit about practical lifestyle advice for hypertension management. Particularly, I'm going to focus on a few of the more in-depth kind of specifics around what we should be advising patients. So we're going to talk about a little bit about what are the guidelines, touching on nutrition and exercise, the two big components of management away from obviously medication, and then perhaps a little bit about other considerations at the end. And we might get into that a little bit more perhaps in the Q&As towards the end of this talk. So first, we're going to start with what the guidelines say. Well, obviously our kind of overarching guidance is determined by the NICE guidelines, and the latest reviews in 2019. And I've just underlined in red the kind of key points. So we all know that lifestyle is an important part of management of blood pressure. So we talk about offering lifestyle advice. That's been in there since 2004. So it's asking about diet and exercise pattern. Alcohol, it's been kind of amended in 2019. Salt intake, perhaps probably the most common one, where we ask around about what should we be doing to manage our blood pressure. I think most patients will be aware of that. And obviously your usual things like smoking as well. But what you'll probably notice from each of these, and to be fair, guidelines are there as a general guidance rather than specifics. They are still quite vague. And even if you look at the ACSM guidelines, so over in America, you look at the BIHS guidelines, you look at BPUK, any of those guidelines, and they all have a similar amount of vagary, all about make sure your patient's exercising, make sure you investigate their nutrition, but not specifically about how much should they be doing in terms of exercise, what intensity, how regularly, what should be their key considerations with nutrition. So hopefully we can explore that a little bit more today. So as I mentioned before, salt and hypertension is probably the most prominent piece of advice that we're all aware of. And that's rightly so. It's been very well studied, all the way back to the INTERSALT study, which is kind of the landmark study probably in this area, back in 1988. And there's salt and blood pressure ever since has been well studied. And there's been consistently shown to be a strong correlation between salt, or more specifically sodium intake, and blood pressure. And conversely, with that correlation, if we're able to reduce our sodium intake, so for example, in 1991, study by Laura et al. Showed that 100 millimeter per day reduction in sodium intake, which is about the equivalent of 6 grams of table salt, which is not that much. The daily recommendation is actually 6 grams, albeit not very many of us stick close to it, can change systolic blood pressure by 10 millimeters of mercury in older adults. So these are people over 60. A worldwide reduction is predicted if we were to reduce by our sodium by 50 millimoles per day, so half what we just saw in the last bullet point. We could reduce the need for antihypertensive predicted by about 50%, which the financial and socio-economic and side effect implications in that are massive. And there's just a couple of graphs here to kind of demonstrate what we're looking at. So salt is probably the strongest nutritional component, and it's really important we have to do. When we're looking at that, we're looking to getting under that 6 grams per day of salt intake, and that's just about a teaspoon worth of salt. So not much. If you think about seasoning your food, that's not a great amount at all, and particularly if you're eating processed food. Next time you look at the package, you look at the traffic light system, quite a lot will in itself have 6 grams of salt, let alone your other 2 or 3 meals a day. So when we talk a bit more about nutrition, obviously we don't only one component of our diet, we have a multifaceted dietary component. And probably one of the most famous diets for trying to tackle this is the DASH diet. Okay, so this was developed over in America, the dietary approaches to stop hypertension. And if you look at the chart in the top left, that plate of food there, it's a fairly common kind of well-balanced diet. It's been recommended for decades by the AHA for non-pharmacological management of hypertension, and indeed even for those people on medication. And it's been around since the early 2000s. And you can see from this this plot on the right that meta-analyses have shown that on the whole, it generally has a pretty good effect, around about 7 millimeters of mercury in terms of the effect when we look across all the studies, albeit there have been studies that have shown a non-significant impact of the diet. And these are typically compared to a standard American US diet. And obviously our diet over in the UK is typically slightly different to the US diet, so typically slightly less refined than the evidence shows, although it is creeping towards that. So clearly this does have beneficial effects, and it's a good place to start to advise our patients on where to go. And it has our kind of pretty classical healthy nutritional intake. So fruit and veg 4 or 5 times a day, low fat dairy, albeit the evidence on low fat dairy is starting to change, and kind of normal fat dairy is perhaps arguably better for us because of some of the fat and nutrient intake. Limit our fats and sweets. Okay, again, fats are a bit contested at the moment. Legumes and nuts and seeds, so they're going to have some of our unsaturated fats, lean protein, and grains. So this is obviously, again, targeting quite a lot about salt and processed food intake, but is salt all we need to consider? Well, in short, no. And hopefully the bullet points show here. I'm not going to go through all these bullet points, but these are just a list with a quick literature review of all the different ones you can see. And obviously all of them have slightly differing effects in terms of pathways and magnitude of effect, and slightly different considerations to take into account. But salt's perhaps the most influential, but plenty of other factors have to play. In other words, it's important to consider the whole dietary intake and also a relationship between obesity, losing weight, and physical activity as well, which we'll talk about in a moment. There's quite a lot of different components that are not particularly well studied at the moment, but show promise. So things like L-arginine and L-carnitine as part of our amino acids have an effect in terms of sterols on blood pressure pathways with nitrous oxide production. And also the interaction of plant-based foods versus animal-based foods. And obviously plant-based diets, particularly with it being January, and perhaps some of you out there taking on veganuary, is an interesting point of view to have a look at. So overall, and again, I'm not going to go through this slide in detail, there's lots of considerations to make, and I'd recommend you go and take a look at this paper published in the World Journal of Cardiology back in 2014 by Houston. And it's got some really nice kind of bullet point recommendations, and almost works as a bit of a crib sheet to say, here's the evidence, this is what it says. And this is a great kind of menu to choose from that you can obviously take and tailor to your patients, depending on the advice that they require in terms of their lifestyle changes. So we've talked a bit about nutrition there, but actually I want to talk a little bit more, and I'm perhaps a bit biased in this in terms of being a physio, around exercise and hypertension. Now, particularly, and this is perhaps where I got my soapbox, particularly here the advice and guidance is particularly vague about taking part in exercise, but often there's lots of fears and kind of confusion on where to start for these individuals. Now, we generally know there is a dose-response relationship between physical activity and blood pressure, and actually that tends to be the case for most things, albeit some have a J-curve, such as heart rhythm and arrhythmia issues, for example. Now, the 2018 guidelines, the European Society of Cardiology, are probably the most specific that are out there, and they recommend 5 to 7 days of over 30 minutes of aerobic activities. That's cardiovascular type training, so that might be anything from walking to running to rowing to swimming. 2 to 3 days of resistance. Now, obviously, if you take a patient who's doing absolutely nothing each week, and you ask them to theoretically do between 8 to 10 sessions per week, you're obviously perhaps going to scare them off. So it's important to look at where our priorities are in terms of integrating exercise as a component of lifestyle management. Now, it's important here to have a look at where our biggest wins are, and I'm a big believer in those little movements to the big wins. Now, aerobic exercise from the evidence seem to have the most prolific effect on blood pressure, so 4 to 12 millimeters of mercury reduction in systolic blood pressure, depending on which study you read, whereas resistance is around 2 to 7, and typically lower towards that 2 mark, albeit has positive health benefits elsewhere. But this is significant still, given the fact that a 2 millimeter reduction in systolic blood pressure in a hypertensive patient can amount to about a 6% reduction in the risk of cardiovascular disease incidence. So we're talking heart attacks, strokes, etc. And a reduction in about, conversely, 10 METs per week of physical activity actually has the opposite effect. So it increases risk by about 6% of developing hypertension. So it really is a swinging balance here that we've got to get right. And anything we can do to get our patients a bit more active is going to have a really profound effect. So how do we go about prescribing exercise? Well, some of you may come across this really quite simple principle of prescribing exercise, and this is used not just in hypertension, but across any exercise prescription, so from your local PT up to your Olympic athletes. This is the FIT principle, so that's frequency, intensity, time, and type. So 4 parameters that you can give to your patients to guide them on how much to do. So we're talking frequency, how often, essentially, how many sessions per week, and in what form. Intensity, how hard should they be pushing? Time, how long for, and type, what should they be doing? What's the modality? Aerobic resistance, is there a specific type of aerobic, etc., etc. The important thing, as I've kind of exclaimed at the bottom, is make it bespoke to the patient. That is going to get the ultimate buy-in, just like you would in any other advice. There's no point in asking them to get swimming if they live nowhere near a swimming pool. So key things here are to remember to discuss with the patient, what is their exercise history? Have they enjoyed any form of exercise before? Or are they familiar with any form of exercise? Is that more likely to get them back, or did that put them off last time and they need to try something else? What are their likes and dislikes? What's their injury history? Do they have knees that are going to stop them from running? What equipment do they have available to them? And other health considerations at all. Obviously, are there any contraindications to them doing certain forms of exercise? Thankfully, with exercise, there's typically ways around every form of medical condition, but sometimes it's harder, easier said than done. So we're going to go through each 4 of those now and see what the evidence says. So frequency. Well, actually, what we can see is that most, if not all days, are best. Now, when I tell patients, oh, it's good for you to exercise most days, they look at me pretty scared like rabbit in headlights. What this typically means actually is just getting active most days. So actually what I recommend for most of my patients is try and walk for half an hour a day. Now, for some people, that's a 30-minute walk with the dog in the morning. Some people, that's 6 lots of 5 minutes around the house because they can't manage much more. And then for our higher function athletes, we can look at doing a little bit more in terms of jogging, rowing, running, swimming, whatever it happens to be. Now, the positive impact starts as soon as they start to exercise. So an acute bout of exercise can actually reduce our blood pressure over the next 10 to 24 hours. If we do that every day, all of a sudden, we have a consistent application of our post-exercise hypertension effect. And that, without the chronic effects, is going to have a really positive effect. Now, the studies have shown generally that even the acute bouts, a single acute bout of exercise, can have an acute reduction of around 3 to 12 millimeters of mercury in systolic blood pressure. So therefore, days where we exercise, naturally our blood pressure is going to be lower. The more we can string together, clearly the better. It's similar to taking our medication. On the days that we take our medication, it's going to be helpful. On the days we don't, it's not going to be as helpful, and the half-life is going to change, obviously. Obviously, the other benefit to most, if not all days, is we accumulate the chronic effects more often. The last point to say, and actually this is a point that I perhaps should have made at the start, is these benefits of exercise are mostly independent of weight loss. But of course, the more we exercise, the easier it is to accumulate weight loss. Nutrition is always the primary consideration here. But if we exercise more, we have a larger total daily energy expenditure, and that makes it easier for us to accumulate a calorie deficit. So intensity. Intensity, well, simply this shows a dose-response relationship within reason to blood pressure reductions and intensity. And I'm not sure how well, hopefully you can see the table up in the top right, but this has quite a nice kind of guideline on what intensities are there. So when we talk about low intensity light exercise, we're talking around about 40% VO2 max or low. Now, VO2 max is easily measured if we have the right equipment, so CPET testing, okay, but not everyone has access to a CPET. So actually thinking about heart rate max, heart rate reserve, and RPE are all readily available. So heart rate, we can measure using a heart rate watch, heart rate strap. Most commercially available sports watches have some form, and they're fairly accurate nowadays. We can make out our heart rate max by taking our age from 220. That gives our heart rate max, and then we can calculate a percentage from there. RPE, that's rate of perceived exertion. So how hard are you working subjectively? There's the 6 to 20 ball scale, or there's a simple 0 to 10 scale, 10 being the hardest, 0 being the least. And we can see here by this review by Pescatello et al. In 2015 that there was a slightly stronger change in those with vigorous activity as we go through. The other thing to look at is actually, and we haven't got time to cover it today, is HIIT as well. So the HIIT is high intensity interval training, and actually there's evidence started to emerge that when safe to do so, that could be more powerful or more potent acutely. However, because it does require the patient to work much more intensely, albeit for a short amount of time, there are some drawbacks to that in terms of patient motivation, perhaps risks. We're not sure of the risks yet, albeit it is safe. And we're kind of looking into that a little bit more. When we look at time, the general consensus is nice and easily over 30 minutes. However, we have to caveat that because there have been studies that showed if you go less than that, it still could be effective. So one study showed as little as 15 minutes could be effective. Now, for most people, that's fairly achievable. Another study showed 3 times 10 minutes. So these two graphs on the right, you can see the effect here. But you can see that longer exercise in the cases had a more significant effect. So there is a time dose response as well. Now, all of these, it was done at over 40% VO2 max. If we remember back to our old table, that's just a low intensity exercise. Basically, anyone who exercises is typically going to be reaching above that. And then we're going to talk about type. So type of exercise, and this was a really nice article by Gravy. I think it was in the ESC journal from memory, or the ESC website, sorry. And it's a really nice one of looking at priorities of exercise. And for most people, the priority should be our cardiovascular exercise. That's our first type we want to go to. If we can achieve that, add in some resistance exercise. And if we can achieve that, perhaps add in some isometric exercise, which also has its place as well. But certainly for most people, the most achievable, the easiest to access, and of course the cheapest, is our aerobic training. What is worth noting is there's not a lot of evidence yet on combination training. This is something we're actually studying ourselves, of actually what's more potent. Is it better to put all our eggs in one basket or to mix it up? And hopefully we'll have some research on that in the next few months. So the last couple of things to look at is, I often get asked by my patients, well, is there a risk here with exercise? My doctor has told me my blood pressure is too high, and actually I shouldn't exercise because it'll push it higher. Well, technically, yes, the blood pressure will go higher in exercise, but then you'll have quite a significant post-exercise hypotensive effect where it'll come down. So actually the risk far outweighs the rewards. The rewards far outweigh the risk. And we have a lot of studies to back this up. So 1 cardiac event per 100 years of vigorous activity for all cardiovascular disease pathologies. Okay, that's a lot of activity for 1 cardiac event. We can assess the CVD risk using Q risk scores. That gives us an idea. There's other studies that have had over 17,000 hours worth of training across 500 patients and showed no events. And even in our own data, we've had about 2,000 patients over the previous 5 years and have had no adverse events through exercise to date. And fingers crossed it stays that way. So the benefits far outweigh the risk in this case. So is there anything else? Well, to wrap up quickly, because I'm conscious of time, yes, there are. And there's plenty of other health and lifestyle things we should investigate. Now, I'm a physio, so I'm not an expert in these areas, but there are people out there that will be able to help. So sleep has a significant effect. Stress, of course, both acute and chronic. And there is good evidence, although it has been removed from the NICE guidance recently, around mild mindfulness and relaxation therapies. More research is needed here, hence the removal from the NICE guidelines, but I think it is an area of promise. Smoking cessation, of course, and then secondary causes. Are there any underlying pathologies that we need to exclude? So to wrap up, your prescription. So if you take one thing away from this, hopefully it's this. This is your prescription to go away, go into the new year and fill your resolutions with. So mostly aerobic with a bit of resistance exercise, as many days a week, but aiming for 3+. Ideally 30 minutes, but something is better than nothing. Over 40% heart rate max. And advise that to everyone that it's safe to exercise to do so. Here are my references. And thank you very much for your time. Feel free to contact me on Twitter, or of course, ask some questions after this. Thank you very much, and I hope you've had a good evening.
Thank you very much. Excellent talks, and thanks very much all of you for your contribution. Now we're going to the Q&A section, and just to encourage people, there are quite a lot already, and we'll start very shortly, but just to encourage people to ask questions, and it doesn't necessarily have to be limited to the presentations you've heard this evening. Feel free to ask anything about hypertension. We have a multidisciplinary panel who are very experienced in the management of hypertension, and we'll just put the questions to the panel. So I'm going to start with the first question, and I think this is a question that sort of Amy's asked, and I think it will go to perhaps the whole group, even though Philip spoke specifically about it. When a patient asks you what home blood pressure machine they should buy, what do you say?
So I take that.
Yeah.
Well, sometimes they come with their machine, and if they don't, then you've got to. it depends, one, what you've got available. I always say, please get a validated machine. And also I carry in my clinic some machines with me that I think are more accurate than others, because I don't think they're all equally accurate, although they're validated. And what I actually do, as you saw, is I connect a 3-way tap to the machine and listen while the machine records, and I compare the two. And I prefer to do that rather than guess, but it depends on their arm cuff, their budget. More expensive does not mean a better machine. So not being promotional, I say follow the guidelines that in our website about what's approved, and the better known ones are as good as any. But just because it's expensive doesn't mean it's better.
Okay. Thanks, Philip. Thanks, Naomi. Yeah, come on.
This is a very, very common question that I got asked when I was in practice. And I tend to say to people, buy the best machine that you can afford. So whatever that may be, whatever their limitations are, choose the best that they are able to afford. And as Philip said, not being promotional, because there are plenty of other makes available. And I also show them what I had and show them options. The other point is to look at their age and their technical ability as to whether or not you go, I won't say high-tech expensive, because there are some high-tech monitors now that are not expensive, whereby they can monitor their BP with digital intervention. So again, it's a discussion about whether or not they want to do it that way, or, the old-fashioned way with a piece of paper.
Thanks, Naomi. Thank you, Philip. But any other, sort of variation on those answers? I mean, when I'm talking, I normally say to patients, don't spend more than £25 on a monitor. And Alison, you're going to disagree or not?
No, I was just going to say it's just worth reminding the patients that they want an upper arm cuff one rather than a wrist monitor. And then obviously you can make an assessment if you're seeing the patient, or you can have that conversation about the cuff size, which Philip did point out in his presentation. But that's really important. I've seen some patients with fairly inaccurate blood pressure readings because they've been using completely wrong cuff size, like a normal cuff on a very large arm. The other thing, I think sometimes people are not sure if their blood pressure reading is reading accurately. So it can be useful to get them to bring the machine in and use their machine in the clinic, and then use your machine, and then just do a comparison if you're not sure about the readings that they're producing for you, just to make sure that their machine is reading accurately.
Okay, thanks very much, Alison. I mean, so hypertension is often complicated by atrial fibrillation, and yet we are encouraging. There's this drive towards measuring blood pressure at home. But any comments or suggestions regarding ABPM home monitoring in patients who have atrial fibrillation? Any way forward?
Yes, can I come in on that? First of all, those monitors which shall say AF detecting aren't actually detecting AF. They're detecting the irregularity, which is possibly or probably AF. So it's not a diagnosis of AF, and it does need to be confirmed with some electrocardiographic proof before you consider anticoagulation, for instance. So don't assume it just because it's irregular. It is AF, although it may say AF detected. That's the first thing. The other thing is that you still have to use a validated monitor, and it's better, because of the variation pulse to pulse in AF, to measure the blood pressure 3 times rather than twice. But as a whole, if you are using the monitor for home assessment, there's no reason why triple readings, in the same way as we do double readings of other people, are not in most people reliable. And it's always worth checking, as Alison's just said, in the clinic, their machine versus what you're reading.
Okay, thank you. Any other comments on that? Yeah, Alison?
I was just going to make a comment about it's good practice to do a pulse check for all of your hypertension patients. You will find patients with undiagnosed atrial fibrillation, and it's any of the long-term condition reviews is a great opportunity to pick up those patients with an irregular pulse, and if necessary further investigate, because they may be people that should be thinking about anticoagulation. But as Philip said, it's not diagnostic by feeling the irregular pulse. It needs further evaluation.
Thank you, Alison. Thank you. I mean, we are encouraging many more patients to have their own machines, but clearly there will be patients who cannot afford these machines. I mean, is there a way around it? I know I've written, sort of GPs in the past to say how we can help patients. I mean, is there any source of free blood pressure monitors, for instance, or as Terry's asking, should this be on a prescription? And this is to the whole panel, to everyone.
Well, as Richard said, there are 200,000 monitors that have been donated or bought by the NHS to be given out. So I suspect perhaps as a society, we should be trying to look at where they're going, maybe help direct them to the correct patients.
Can I comment on that? Because I'm part of the group on the delivery of these. They've already gone out to the various PCTs. They're not necessarily in the hands of patients yet, but GPs are so busy at the time, they're finding it really difficult to deploy them because they've got also other demands. So the first thing is, the question was, what do you do if you can't afford a monitor? Well, sometimes can't afford is a relative phenomenon. So you can afford a Starbucks several times, but you can't afford a monitor at 20 to 25 quid. That's not always true. And most of my patients who plead poverty have often got mobile phones, which cost more than that. However, there's two things you can do. One, your GP may well be able to provide you with one and lend it to you. Secondly, now pharmacies, there's over 2,000 pharmacies in the UK now that are setting up to measure both ambulatory readings, individual readings, and also loan monitors to patients for which they will not make a charge. So that's what you should do, and make sure your local pharmacies have shown some interest in this if they haven't already.
Thanks very much, Philip. And in terms of, sort of acceptance of, I mean, there's, again, a constant drive towards moving measurement of blood pressure into the home. I mean, what do patients generally think about this? And the other thing is, Richard talked a lot about telemonitoring. Is this something patients are engaged with? Does anyone have any experience where this is already happening?
If I could take this one, I think we're finding that if we relate it to I think most people see blood pressure as this one-off value or something that's taking seldom unless they're kind of forced to, and then it becomes quite a scary value. What we've been working on with a lot of our patients is relating it more to like stepping on the scales. It's a check-in, it's a snapshot of how you're doing there. There's lots of factors that affect it. So one bad reading doesn't necessarily make it the end of the world. The same as one good reading doesn't mean that all your problems are solved. And it's something to be checking regularly. With telemonitoring, we're kind of seeing with different technologies and different apps coming out that people are being much more willing to be able to take it every other day, a couple of times a week, or even every day in some cases, because they are seeing it more in that way. And with the exercise work that we're doing, there's a really acute change that you can see pre and post session even to see that. And it can be really empowering for patients to see that acute change, which then encourages them to take it further because they like to see those changes in the same way that everyone, when they step on the scale, likes to see the number goes down. It's a similar effect.
Thanks, Sam. That's really helpful. Just go on, Philip. Yeah.
I don't actually manage almost any of my patients by clinic readings at all. I manage almost everybody by home monitoring. Both my maternity patients, or less often, because the trouble is there's very few validated monitors. They are much more likely to possibly look at them there and there. But certainly I manage almost everybody by home monitoring. Alternatively, you can do ambulatory monitoring intermittently. And then in terms of the question about telemetry, I need to see what the average results are. Now, the BPM at home thing, people are using Accurix or Flores via Florence, Flores or Florence or other systems to get feedback. I send my patients, most of them, spreadsheets which they fill in, which automatically average the results, and then they send me them back, and I monitor them that way particularly. But there's a whole art form of telemetry going on now, and some, of course, automatically download, but not that many at present.
Okay, Thank you, Philip. Just for some clarification, because obviously this is a very sort of eminent panel, and we just want to give a clear message to the attendees of this webinar. What is for patients who have atrial fibrillation, what is the messaging around home blood pressure measurements? Are patients still allowed to use automated monitors or not?
Yes.
Okay, so simple yes. So that's a clarification. So I'm going to sort of leave, we'll come back to the measurement of blood pressure very shortly, but I'm going to sort of pick up on something someone mentioned earlier on, and I can't find the question now, but it's around supplements, Sam. So supplements, what's your position on supplements? So patients come in and they say they're taking omega-3 tablets or something like that. Is it preferable to advise a diet rich in oily fish, or is that an acceptable sort of management of hypertension, so to speak?
So it's an interesting one, and I think everyone is always often looking for a quicker fix or a kind of tablet that will solve everything. And unfortunately, there's no evidence out there to suggest that one single supplement is going to have a profound effect. With the omega oils, there is some evidence out there that they can have a small effect on blood pressure, and those studies were using mostly supplements rather than oily fish. But it's nothing in comparison to your medications or your exercise or things like that. There is some evidence ongoing on cherry juice extract and beetroot juice for its nitrate content, again, which has shown quite good evidence. So I would certainly be saying there's no harm in individuals having a nitrate-rich diet, lots of beetroot, lots of green vegetables, those kind of things, because that has lots of other benefits for your general health. So for my patients, I'm always advising that actually a nice rounded diet that contains oily fish, not much processed food, lower salt, nitrates, all these kind of things, proteins, there's things around amino acids as well. So that's plant-based proteins, particularly with legumes and things, is going to do your health wonders, not just for your blood pressure, but for weight loss, for cholesterol, all these kind of things. So there's no harm in doing it. But if they're going to leave it purely down to a single food source to affect their blood pressure, it's unfortunately probably unlikely to be that easy.
Thanks, Sam. Any other comments on that? Anything else? Any other practical advice?
You have to be careful about some supplements that they can do exactly the opposite. So things like, I had one patient, for instance, who was taking black cohosh, thinking it was good for his general health, but it certainly put his blood pressure up a lot. And once he stopped it, his blood pressure normalized. And the other thing about using nitrate-rich things like 250 mils of beetroot juice a day is you can't use Listerine, because if you kill the bacteria in your mouth, you stop the activation of the nitrate in the stuff. So there's ways of doing it, and there's things not to do as well.
The other point I would just make is that we do encourage a very high diet of vegetables, as Sam was saying, legumes, nitrates, but people with bowel disease suffer terribly. And when we're treating hypertension, we actually have to look right the way across the board holistically, because if you do have someone with some sort of bowel disease, you cannot advise the same diet. And I've had people come to me and say, look, this is the situation, this is what I've been advised, and it just needs a little bit more of a holistic view.
Thanks, Naomi. Yeah, Alison.
To make a comment about salt and salt substitutes. So Sam talked about salt and the effect on blood pressure, and there are some salt substitutes. Most of them are potassium based, and I did notice on your slide, Sam, you did put a caution around the medications, but remember, if patients are on anything that blocks the renin-angiotensin system, so ACE inhibitors, angiotensin receptor blockers, and of course spironolactone, which is are very effective in more resistant hypertension, then you do need to be careful that you don't result with hyperkalemia. And if your patient's potassium is a lot higher than you expect it to be, it's always worth checking that they're not using some form of salt substitutes.
Thanks, Alison. So nighttime blood pressure is quite topical now, and it apparently correlates very well with cardiovascular risk. Now, in moving the measurement of blood pressure into the homes, how do we get about sort of measuring nighttime blood pressure, or do we continue to perform ambulatory blood pressure monitoring so that it happens every hour, or is there any other way around this?
Can I comment on that one?
Yep, Philip. Yeah.
Right. First of all, there's a group of people who will have higher nighttime blood pressure. They'll never know about it, and that will only be shown normally by ambulatory blood pressure profiles. But there are now some machines which will do a delayed nighttime reading. So there is technology there, but it's not usually present. So the way I deal with this is I get the daytime right first, based on ambulatory home readings. When I know that the daytime is within target, which might be less than 135, 85 average for someone less than 80, then I'll do an ambulatory profile to see if the night time's okay. But clues as to hidden nocturnal or masked hypertension where outside readings may be higher might be increased left ventricular hypertrophy you've not spotted. And you've got to think of things like obstructive sleep apnea and things like that. So I think there's machinery coming on to do it. Ambulatory blood pressures will tell us. But in terms of the other thing is, of course, there was one paper called the Hygeia study from Hermida in Vigo in Spain, in a large group of people. And he said, oh, yes, giving blood pressure treatment at night is better. Now, that study, which people have immediately jumped on, has been questioned in the literature. And I don't think that you should put your eggs in that one basket at the moment. The BIHS with Tom McDonald in Dundee's sponsored a study called Treatment in Morning or Evening Time. That hasn't reported yet, and we'll look forward to that report. But we wouldn't say jump on the giving blood pressure at night unless the blood pressure we know is particularly high at night, and the morning blood pressure is still high and the afternoon ones or evening ones are low, in which case I'd say there may be a point to do it, but not as a rule.
Thanks, Philip. Any other comments? If not, just moving on to postural hypotension, orthostatic hypotension. So in primary care, for an annual review, and what sort of measurements are appropriate, for a patient who either has established orthostatic hypotension, or you're looking for it. So say, for instance, they're a bit older and they've got diabetes. What is the procedure? What do you measure? And what is it you treat?
Dare I jump in again, or Naomi, do you want to come in first?
No, I was just going to say that with that type of patient, that we would do obviously lying and standing, and not just the sitting. That would give us a better representation of the real blood pressure and what we were treating. And also, they might be the sort of patients if they were on alpha blockers, that I might encourage the patients to take the medication at night, depending on their symptoms.
I'm going to differ slightly on this one.
Okay.
I measure blood pressure in everybody sitting and standing, because it doesn't take me 2 seconds to then stand them up. So the patient who's had their blood pressure established and they've come, and I'll do, I just happen to do 3 readings every time anyway, and the favored arm, the higher arm, and then immediately I stand them up. I just do it so automatically now, I don't think twice about it, and it's interesting how much blood pressure drops. The most important is when it drops enough to cause symptoms. And of course, in older people, it tends to drop immediately they stand, whereas in younger people, it may take time to develop. That's why I've suggested in my talk that you measure blood pressure immediately on standing in 1 minute, but in younger people, you might think about 3 and 5 minutes. Obviously, if they do have standing hypotension, it's, as you've alluded to, it's often the alpha blocker, may even be tamsulosin given for prostatism or whatever. And you can change it to a sort of a weaker drug like alfuzacin and a half dose and things like that. You can get the patients to wear support stockings. You can sometimes, and obviously that's then a whole treatment of hypotension. So I routinely measure it because you never know otherwise, but not everybody does. And especially in people who are at risk, especially older or frail people.
So which blood pressure do you treat if there is a drop? Which blood pressure is the treating blood pressure? And is there any clarification on what you should treat in that situation?
You treat I personally think you treat the average blood pressure, but if they have postural symptoms, then you may have to modify that if you can't modify the agent, so that you treat them to the point where they are no longer symptomatic.
Any other comments on that? Alison, want to come in at all? Make any comment on orthostatic hypotension treatment?
I mean, most of it's pharmacological, non-pharmacological, or there's some exercises and things that Sam might want to comment on that may be helpful for patients with postural hypotension. It is quite difficult, and you'll often have to modify your target for the patient. I think the NICE guidance actually says you use the standing blood pressure as the blood pressure reading that you use for where you're at, but you often can't get to where you want to get. You just have to accept that for that individual patient that's you're not going to be able to get them to, in inverted commas, to target.
Fantastic, thank you.
Yeah,
Sam, go on. Yeah.
Sorry. I think in terms of, obviously, measurement and treatment is slightly different, but in terms of treatment, there's a lot of good evidence for exercise supporting it quite well, both resistance exercise and aerobic exercise, so helping with the mechanisms involved in the vascular shunt to allow that, and to help with the dynamic kind of capillarization effect. So it can be a really effective thing if an individual is suffering, and particularly if medication is not perhaps having the desired effect, then an exercise intervention can be really helpful.
Thanks, Sam. So just going to introduce a slightly controversial, sort of not a question, but comment. And, should we be measuring blood pressure in GP waiting rooms? Because Philip, you mentioned that majority of your patients, you don't actually measure their blood pressures in clinic. So now that there's this drive or encouragement to get patients measuring their blood pressures at home, should we be doing that in the GP waiting room, for instance?
Actually, I didn't say. I said I always measure blood pressure in clinic, but I don't make my decisions on it.
I see.
Because it may be, as you know, 10-15% of people at least have masked hypertension. 10 to 15% of people at least have white coat hypertension, more higher in older people. So that's why I don't make decisions on it, but I still use it as a guideline to know where we were. But for instance, I had a pregnant lady whose blood pressure at 18 weeks was 180/120. Her home blood pressures were 120/70. So every time she came to clinic, I still measured it. It was still horrendously high, but I didn't make any decisions based on that whatsoever. So, sorry, Mike, I missed your question. I was so busy thinking about that.
No, not at all. Just whether we should be doing blood pressure measurements in the GP waiting room or not. Someone's asking, and I think it's a valid question, and I can see Naomi wanting to contribute as well.
Yeah, my experience of this has not been always very helpful. Patients get themselves very uptight because they're sitting in often a very busy waiting room, not during the pandemic, but prior to the pandemic, and they're putting their arms into a machine that's very public. And so often they see the first reading and they think, oh my goodness, and you obviously tell them to do it again and again, do it 3 times, but there's a huge element of stress. And I know it's anecdotal and we need to collect some more evidence about these machines, but on a personal level, I find that they very often agitate the patients.
We used a kiosk machine in a variety of public places in Stockport. In about eight of them, 40% of people registered elevated blood pressures using that technique. But it's a good screening tool in the sense that if your blood pressure is normal, you're not going to worry about it. But it doesn't make you have the diagnosis of hypertension, and it might be that it might reduce GP time. One interesting is there's one paper that showed that if you measure the blood pressure 15 minutes afterwards, it may normalize and reduce the need to look for ambulatory profiling. And the other thing, of course, is unobserved blood pressure, which was in the SPRINT trial, where the Omron 907 machine was used, and where you press the machine, the patient's in a quiet area, if you can find one, it does nothing for 5 minutes and then does 3 readings at 1 minute intervals and averages those 3 readings. and that is about 20/10 lower than an equivalent clinic reading. That's another thing that can be used, but how many GPs have got places to do that in the UK? The answer is not many, I don't think.
Thanks very much, Philip. So just talking about referrals into secondary tertiary care from primary care, so we know that over 90% of individuals will have primary, so-called essential hypertension. So someone's asking if they have a 40-year-old or someone who's above 40, perhaps strong family history, and you make a clinical diagnosis of a primary hypertension, is there any need to refer them on into secondary tertiary care for investigations?
I'm biased, I think so, because especially under the age of 40, the NICE guideline says someone less than 40 should be referred anyway. Yeah, but if you haven't got someone down to target under the on 3 drugs, appropriate drugs and appropriate and maximum tolerated doses, that's another clear, nice recommended guideline that they should be referred. So the minimum the NICE guidance says anyone under 40 should be referred for looking for secondary hypertension, and anybody on more than 3, not at target, on 3 or more appropriate drugs in maximum tolerated doses should also be referred. I think that's very clear.
Thanks very much, Philip. So maybe Sam, this is to you. Is there any situation in which you would say exercise is a complete no-no in someone who has hypertension?
I think before you're prescribing exercise to anyone, full stop, really, that we have to do our basic screening tools. So they may be subjective, such as their exercise history. Obviously, the other medical history, as Naomi referred to earlier, is about the holistic approach. We will typically not utilize resistance training in anyone who sits at a resting blood pressure of 160 or above systolically, or 100 above, because it has an increase in our peripheral vascular resistance, which can cause localized issues. So we would tend to then modify to only walking. I think there's very few patients where a simple walk would be inappropriate, because frankly, if they are able to get to the clinic to see me, then they're probably well enough to go for a small walk. So it's about scaling the exercise, I think, for the appropriateness.
Thanks very much, Sam. I guess there's so many questions here, really interesting ones. Just the final one, perhaps Alison, you might want to comment. Would you advise titrating fully on one medication before adding in another one? As there is experience based on a lot of patients appear to be on 2 to 4 different antihypertensives at suboptimal doses.
Yeah, I think there's probably 2 schools of thought on that, and one is start with one medication, titrate. There is some thought that if you actually start with one, or even in some of the guidelines, I think the European ones start some groups of people straight on with 2 medications, and say smaller doses of 2 medications may be more efficacious than titrating to top dose of one medication. So that's probably where it comes from. I think the other important thing to remember is that many patients will need more than one class of antihypertensives to get to target. It's not unusual to need 2 or 3 drugs in many patients. Philip, you're nodding. I don't know if you want to add anything about how you practice.
Well, Malcolm Law wrote a summary on this, which said that adding a second drug is 5 times more effective than doubling the first. So our new guidelines in Manchester we're drawing up will clearly say that. Start with middle dose of your ACE inhibitor if you're less than 55, for instance, and then immediately add a calcium channel blocker before you would think about titrating up. And I think there's reasonably good evidence for that.
Thank you so much. I wish we could carry on for several more hours. So many questions here, and we'll go through them and see if we can respond to them in some shape or form. I just want to say a big thank you to all the members of the panel, multidisciplinary panel, and that's the style of BIHS, and anyone who has spoken today. We're very, very grateful to you, and again to the BIHS for supporting this sort of in trying to reach out to colleagues in order to equip them and empower them to be able to manage hypertension and related disorders much better. would also like to thank all the attendees for attending, because without you, it wouldn't, be so fun. This is the very first of hopefully many more webinars that the BIHS will organise, and I encourage you to sort of be on the lookout for advertisements regarding future webinars, and we will try and make it as practical as possible. Well, thank you very much, everyone. I think we've come to the end of this webinar, and look forward to seeing you again soon. Thank you.